So far, we kind of did some background stuff as far as the patient care process. Now we want to talk about actually looking and touching the patient at some point, and that includes the patient assessment. And that's what all of this stuff will end up being. The first three are just kind of some background information about where we gather information from, and then we'll get into actually hands-on doing. If we remember back to the performance evaluation, the first person who's starting us off is going to do is the person who's doing the bed boost, and we want to do for chart review. We just want to do a walking in the patient's room, seeing what they look like. So we're looking at a critical life functions. We're also going to look at a scene survey to make sure entering that room is not something dangerous for whatever reason, and verifying if the patient is even there. If you can't treat the patient, obviously, if they're off down in radiology. Again, that scene survey, we talked about this before. It's what we do that when we're first entering the scene. In our case, it's going to be the hospital, the patient room. Could also be the emergency department as far as being called down there for an intervention of some kind. We don't really deal with the accident scene, but if you talk to is there any EMT paramedic? Yeah. What they're taught is always to make sure they pound the scene survey into them, because they may be in a situation where you're going to somebody's home and there's all kind of things that are dangerous inside that area. So, and we're looking for that hazardous situation. Remember back to that picture that we looked at with the guy who was sitting in bed smoking and the frayed cords and everything else. Then we're going to do our primary survey. Our primary survey is looking at those critical life functions, and there's 4 of them. Ventilation being the most important one, because if you're not breathing, then nothing else is going to end up working. The most common problem we encounter is an alteration in the oxygenation status, especially in patients with chronic lung disease. So we're going to look for any immediate life-threatening situations, because absence of any of these critical life functions is an emergency situation, and you can't do anything else until you treat that problem immediately. So let's talk about a little about how we do this observation or measurement involved. So we're going to, as far as ventilation is concerned, we'll take a look at the respiratory rate. Is it high? Is it low? We'll take a look at the chest movement. Do we see chest movement on both sides of the chest or just unilaterally? We'll take a look at and talk about assessment of their breath sounds. What kind of things do I hear when I listen with a stethoscope? We can perhaps measure their tidal volume. You guys did that with Lori in the lab, where you measured their minute ventilation, measured their respiratory rate, and determined average tidal volume. Evaluating their speech. Can they say a sentence as a whole sentence, or is it 1, 2, 3 word bits that they get out? That's telling me that they're very short of breath. When you become extremely dyspneic, you don't have the ability to have a long sentence being delivered. Oxygenation, we can look at their color. It's not always a good sign, but sometimes it'll give us an idea. We can also look at their sensorium. How are they alert? Are they confused? Are they unconscious? And then as far as oxygenation, we can also take a look at measuring their pulse oximetry. We'll talk about heart rate in a second, because that rapid heart rate is usually there for one of 2 reasons. One is a reduction in oxygen levels. The body's first response is to increase the respiratory rate and increase the heart rate. Second thing is blood volume. If my blood volume is low, my heart rate will be increased as a compensatory mechanism. If I do have hypoxemia present, what do I do about it? Put lots of oxygen. That's simple enough. If I have oxygen being delivered, in other words, increasing FiO2, I increase my alveolar PO2, and therefore my arterial PO2. Simple enough. What about if my blood volume is low? What do I do? Yeah, give them fluids. Put an IV in and give them some fluids. Maybe blood, but it may just be some normal saline or dextrose and water. That's what we just talked about. How do we treat them? Now these are some scenarios that'll come up, and we'll talk a little about and see if we can tie this to some of the stuff we're covering in 1050. Can a patient be blue and still be getting enough oxygen?
Big bloaters and big buffers.
That's right. Actually, there are two different types of patients that are have pulmonary disease. One appears pink, one appears blue. So yeah, you can have a patient that is blue and still, but his oxygenation status is acceptable. Can a patient be pink and not be getting enough oxygen? And the answer is yes. We'll talk about why in a second. Can a patient have hypoxemia but not be hypoxic? The answer is yes. Can a patient have hypoxia but not have hypoxemia? And the answer is yes. So let's go through these. And this is a chart that is there looking at various things and how we treat them. And let's start off with our first one, a normal patient. Color is going to be pink. We all look wonderfully well oxygenated. Our hemoglobin's in the normal range. If I were to measure my oxygen saturation, the amount of hemoglobin that is filled up with oxygen, we can do that by drawing some blood, which is the SaO2, or I can measure it through pulse oximetry, what we're going to call the SpO2. In both cases, they'd be perfectly normal. Our hemoglobin would be 100% saturated, and that's the ideal. We know the normal PaO2 range is 80 to 100. So therefore, this thing on the bottom here, which you guys haven't quite got to yet, I don't think, the oxygen content, is the total amount of oxygen you have in your bloodstream. Some of that is dissolved, PaO2. Some of that is attached to hemoglobin. Well, in both cases, the PO2 and the hemoglobin are good. So my oxygen content would be good. The total amount of oxygen being transported in the bloodstream. Does that conceptually make sense? Okay. Let's take another example. We've got a patient who's got chronic hypoxemia. One of the things that happens when a patient is chronically hypoxemic is that they develop more erythrocytes. The body releases a hormone called erythropoietin. Erythropoietin stimulates the bone marrow to produce more erythrocytes. And as you produce more erythrocytes, you also produce more hemoglobin. Vaguely remember this from A&P? In that process, then, someone who has chronic hypoxemia will often have polycythemia. If you were to move to Denver, within about a year and a half, your hemoglobin levels would rise because of the reduced oxygen that is in your alveolus. And you're being a little bit on the hypoxemic side, or at least having a low PaO2, you would generate more hemoglobin in the process. Okay? So here's a patient that actually presents blue. They're blue because they have the blue meaning cyanosis. The cyanosis is classically defined as 5 grams of hemoglobin that are not fully saturated. Well, he's got extra hemoglobin. There's not necessarily extra oxygen attached to that hemoglobin. He just has made more hemoglobin. But it's not carrying anything. So he appears cyanotic. Yeah, polycythemic. Not all that hemoglobin is saturated, as I just said. There's a bunch of it running around that's carrying nothing. His PaO2 maybe a little bit on the low side. So the content appears normal because of that elevated hemoglobin. Okay. But this patient needs oxygen. Even though the oxygen content, the amount of oxygen in the bloodstream is okay, the amount that is actually dissolved is problematic. And we're going to find that that amount that is dissolved is important because it's going to be the thing that pushes the oxygen from the capillary itself.
Why does the patient appear normal?
Patient doesn't appear normal. Patient appears blue. The oxygen content is normal. Because his hemoglobin is elevated. If you want, I can go through the math on it, but for right now, just trust me.
That's asking a lot.
I know.
So like a patient like that potentially lives in Denver their whole lives, will they?
Well, this would be a patient who you might have here. I'm saying you could have a similar scenario moving to Denver having healthy lungs. But you can also see the same scenario here in Michigan where a patient with real severe COPD or a patient who has something called cystic fibrosis that will end us. Okay. They may appear cyanotic, but because their hemoglobin has been elevated, again, compensatorily, the amount of oxygen in their bloodstream is okay, but the PO2 is the problem. Here's a general rule. Whenever your PaO2 is less than 60, you want to start that patient on oxygen. The magic PaO2 number is 60. Why 60? Lori will tell you when we start talking about the oxyhemoglobin dissociation. Okay? 60 is the magic number. Few more scenarios. Let's take the opposite. I got anemia. I have a situation where, for whatever reason, I'm not manufacturing hemoglobin. My hemoglobin level is low. I'm going to appear pink. Okay? But my hemoglobin is low. What's there is saturated well. PaO2 is fine. But the oxygen content, if I calculate that out, because the hemoglobin is low, it's going to be low. And this is where I need to increase the hemoglobin.
Are we pulling that hemoglobin number from their crit, or is that a separate lab?
Separate lab value. Okay. So this is an example where they're not hypoxemic, right? But because this is low, they may be hypoxic. So I can be hypoxemic. I'm sorry, I can have no hypoxemia, but still be hypoxic.
Without science.
Well, you would have clinical signs. You'd be tachycardic. You probably would be end up having some other things going on. In most cases, actually, if not pink, you might actually appear pale,
That's what I was gonna
white.
Well, blue or cyanotic.
Not cyanotic.
Really?
Yeah,
Even with that?
you have to have 5 grams of hemoglobin that are desaturated. They barely got 7. So there's not enough being desaturated to fall into that category. This is a real problem post-operatively. Somebody comes back out of surgery, you can't tell that they're necessarily, just by looking at their skin color, that they're deprived of oxygen. So we need to measure it. Cool? Has she talked about hypoxia and hypoxemia and hypoxia?
Yes.
And the different types of hypoxia?
She gave us the sheet.
They gave you the sheet.
Yeah.
One type of hypoxia is hypoxemic hypoxia. The PO2 is low, so therefore the tissues are sterile. Right? That seems logical. Why is the PaO2 low? What are the causes of hypoxemia? VQ mismatch, diffusion defect, hypoventilation, reduced FiO2, reduced barometric pressure, the whole slew of them. Shunt. Okay? You'll get to that next. But that's hypoxemic hypoxia. I can also have anemic hypoxia. That's this top case. They're hypoxic because their blood just doesn't have enough hemoglobin. And you will find that the amount of oxygen that is transported is vastly, vastly higher being carried by hemoglobin than what is dissolved in the bloodstream. Okay. Another type of anemic hypoxia is the second one. Somebody exposed to carbon monoxide, which is a toxic gas because it competitively binds with hemoglobin and denies oxygen to be carried. So it's just the same as if you didn't have any hemoglobin at all. Because it can't be carried. We'll find there's another one, methemoglobinemia, that exists also. So this is an example where I have no hypoxemia, same as here, but I'm hypoxic. Okay. The tissues are dying simply because the oxygen can't be transported. Now, if you'll notice, this is an important fact. If I put a pulse oximeter on a patient who comes in with, I suspecting carbon monoxide poisoning, Pulse oximeter is full. One of the downsides that we'll find out when we cover that section. It can't identify carbon monoxide as being present. However, when I run it through a device called the CO oximeter, it can be measured. So when I do a blood gas, I can see that the hemoglobin is not adequately saturated. The pulse oximeter will get fooled. Last one, cyanide. Cyanide? Really, Rick? Is there really cyanide poisoning that exists? The answer is yeah. House fires where there's burning plastic. When you burn plastic, you end up having hydrogen cyanide gas released. You can actually have an elevated cyanide level. Cyanide is a nasty, nasty substance. It destroys the mitochondria. It basically makes the mitochondria unable to utilize oxygen. So even though my blood PO2 is good, even though my saturation is good, even though my hemoglobin is good, I'm dead. I can't utilize that oxygen. Bless you. So in both these cases, we need to do something to increase their oxygen level. You get there. You see the distinction I'm making there? Being hypoxemic, but not hypoxic. Being hypoxemic, being hypoxic. And vice versa. Okay. That was painful. Talk about circulation then, whether or not there's a presence of a heartbeat. And we're distinguishing that circulation from perfusion. And perfusion is talking about how good that transfer of oxygen and carbon dioxide at the tissue level is. In the case of circulation, I can certainly measure the heart rate. I can certainly look at the rhythm by putting them on an ECG monitor. And you will get very good at identifying ECG tracings in different dysrhythmias that exist. I can also, by feeling, I can feel the presence of a pulse. I can feel the strength of a pulse. I can feel the rhythm. Is it regular? Is it irregular? Is it weak? Is it bounding? And in perfusion, how well the organ's being perfused. Again, level of consciousness is a very sensitive index. If somebody starts getting squirrely, start being goofy, it may be because they're inadequately perfused. Diaphoresis. What does the body do when it has a low blood pressure? It says, hey, Mr. Big Toe, Mr. Thumb, I'm cutting you off. And it shuts down peripheral blood flow. In the process then, those areas are underperfused and they get diaphoretic, they get sweaty. We can also measure the blood pressure, measure the skin temperature, the urine output, seeing how well the kidneys are functioning, and we can actually do what we call hemodynamics, and that's module F in 1050, and that will make you cry. Just warn you right now. So what do I do about it? If I'm not ventilating, hello, open the airway and ventilate. Seems easy enough to me. If I'm not oxygenating, give them some oxygen. Can I have both of them being problematic? Yeah. Fix them both together. If I have a problem with circulation, stop the bleeding, first of all. That's kind of obvious, but you can forget about that. If necessary, we can do CPR, do external chest compressions, right? Mimicking the circulatory effort. There may be the need to do something called using a defibrillator or using a cardioversion. Those are both examples of electrical therapy where I'm putting energy through the body and trying to restart the heart. And then I can do things using some cardiac drugs. For perfusion, I think we showed in the video using the Trendelenburg position, making it so that the head of the bed is down and the feet are up. It'll actually facilitate bringing blood back into the central circulation. We talked about fluids, and there are some drugs that we'll learn that are vasopressors that alter the ability of the arterioles to regulate blood pressure. Now, why we're going through all this is because those critical life functions are something the NBRC is going to be looking on your board exams that you are able to identify. If I come across a patient and their critical life functions are all intact, but they have some alterations with them, I'm going to go down this pathway. If I have a critical life function that is missing or is severely impaired, I am not going to bother with a bunch of other diagnostics. I'm going to go immediately to fix that problem. So it has to do with a timing issue. Can I be aggressive or can I be conservative? In a case of loss of critical life function, you got to be aggressive. You got time. Missing a critical life function or two. So we talked about this. Open the airway, breathe for the patient, increase the oxygen level, do all those things for circulation and for perfusion. And again, think about somebody's critical life. If I'm conscious and alert, I'm breathing with a pulse, do nothing. Or maybe something minor. If I have an unconscious patient, but they're breathing, what do? Just maintain an airway. Make sure that being unconscious, the tongue doesn't fall back on the back of the throat and occlude the airway. What about if I'm unconscious, not breathing, but I do have a pulse? Can I have that? Yeah. You can have a ventilation without a pulse, not for very long. You could be apneic and still have a heartbeat. Again, not for long, but you can find it. And in that case, we would just support the breathing. Just do what we're going to call rescue breathing. And lastly, unconscious, not breathing, no pulse, start CPR. Now, outside the door, and I'm not quite sure why the college decided to put the AED right outside of my classroom. I'm not taking it personally, but it's okay. We use what are called Zoll. That's the manufacturer's name. The Zoll AED Plus. And this is kind of the sequence. Again, if you find a person that's collapsed, I'm assuming it's not me, or if it's me and you are doing well on your exams and you want me back, you're going to contact campus police. Any campus phone you can dial 911 from. If you're using your cell phone, again, don't call 911. I think I might have mentioned this before. It goes to Clinton Township Police, and then they got to call the college police, and it's a mess. Open the box in the hallway. The box is actually set up so it will sound an alarm. And campus police will be notified that the AED box has been opened. We're going to retrieve the AED, return to the victim, open the AED, and turn it on and follow the prompts. The first thing you do with an AED is turn it on. Might be a test question, just saying. Turn it on. This is what it looks like, and it actually has steps that'll light up as you go around, and placement of the pads themselves. Let me just call up this demo. It's only a few minutes long. You'll get the idea.
Unit okay. Stay calm.
This is what it actually talks to you like.
Check responsiveness.
We're going to shake and shout, "Are you okay? Are you okay?" He says, "Nothing."
Call for help.
Call for help, 911. Don't want to be doing this by yourself for very long.
Attach defib pads to patient's bare chest.
Now notice how these pads are set up. With this brand, it's one big kind of a what's the word I want to use? What was the game? Tetris. There you go. It looks like a Tetris piece, right? And you get it set up so that one is underneath the right shoulder, one is over just below the nipple, basically, and it even has the center part to tell you where to push on the chest to do compressions.
Don't touch patients. Analyze.
While it's analyzing, you don't touch them. You know, tendency always want to go. Somebody says don't touch, you want to touch it, right? What it's looking for is it's looking for a rhythm, shape, and frequency. And if it sees that, it knows that it's a defibrillatable rhythm. If it doesn't, it says no shock advised. Okay, so it depends on if it's a rhythm that should be shocked or not.
Shock advised. Don't touch patient. Press flashing shock button.
So it's going to go ahead and charge itself up, and before you push that button, make sure nobody, including yourself, is touching the patient. Just saying. I've seen situations where somebody was holding the person's wrist or something, and they got shocked too.
Shock delivered.
And now delivered the shock.
Start CPR.
And it'll tell you to go ahead and do compressions, 30 compressions, 2 ventilations, 100 to 120 beats or compressions per minute. It'll even give you a prompt
Push harder.
of what 100 beats per
Good compression.
is. And it'll also sense the depth that that pad has moved to know that you're doing deep enough compressions. How many people have taken CPR in the past? We're all taught the staying alive. You know, well, it's no longer staying alive. It's now the theme from Star Wars. Dun, 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 dun. That's the ring. You think I'm kidding? Now, weirdness to this is you can take the cover and actually put it underneath their shoulders to help maintain the airway open. Now, that's some designer going way over what you need to. But
How you only do that for like pediatric patients and stuff?
do what?
Like raise their shoulders like that?
No, you can do for adults too. And then, yeah. So that's the Zoll AED. And again, are you okay? Call, place the pads. And what you want to do, actually, I probably should make mention of this. The pads are not directly connected to the machine in most models. So what you do is you'll turn it on and it'll say, place pads. You go ahead and you put the pads on, then you take the pad connector and plug it into the box itself. That then tells it, hey, I got something here I can analyze. And then just follow the prompts from there on out. Don't touch the patient. If shock's advised, they'll have you go ahead and it'll charge itself up, it'll shock, and then you can do CPR. Let me pause this. Yeah, we talked about that. Adult placement, if you don't have one like this, again, is below the right clavicle and along below the left nipple. If you have a pediatric patient, most AEDs will have a pediatric patient pads and adult pads. You want to use adults on adults, use peds on peds. With peds, we actually do an AP approach. If you don't have pediatric pads, you can use adult pads on a pediatric patient. It'll still work. What you don't want to do is use pediatric pads on an adult patient. When you plug into pediatric pads, it actually lowers the energy dose that it's going to deliver as an attenuator. It does that. What about if you have a man who's got a real hairy chest?
Pediatric pads and wax them up.
Some of them have razors inside. Some of them have 2 sets of pads. Put one pad on, rip it off, take the hair with it, and reapply new ones. If that, well, he's dead, so he's not going to wake up and cry, okay?
If he does, you save yourself the shock.
There you go. I think I blew this up for you, or have this as one of your handouts after the slide. That's all I got. More of a Christmas thing, but we'll do it now. Questions?